Good morning, everybody, and welcome to the Neurological Framework practice session, sharing session. My name is Stephanie Fraser, and I am the Chief Executive of Cerebral Palsy Scotland, but I also chair the Scottish Government's National Advisory Committee for Neurological Conditions, and I'm delighted to be here chairing this event today. Now, a bit of housekeeping, please could you all mute your microphones? We ask that you keep your microphones muted through the presentations, and we ask that your cameras are turned on if possible, particularly during the facilitated breakout sessions. But if you could keep your microphones muted and then unmute them if you're asking a question, but otherwise it's really disconcerting for any of the presenters. So please mute your microphones. Now, today's event is all about shining a spotlight on some of the work funded through the Neurological Care and Support, a Framework for Action 2020 to 2025. The Neurological Framework was published in December 2019. It had a vision to ensure people can access personalised care and support regardless of their condition or where in Scotland they live. And over the past 3 years, Scottish Government has awarded £2.1 million to 35 projects to improve patient care and support. And these projects have been very wide-ranging in terms of delivery, geographical areas and conditions covered. We hope that this event will raise awareness of approaches taken to improve knowledge and awareness for people with neurological conditions in Scotland, and also get others thinking about how they could link to these projects or enhance service delivery in their own practice areas. We want to look at ways to continue the conversation beyond these sessions, and we hope to provide opportunities to explore some of the work in more detail through appropriate networks. Commitment 12 from the framework includes pledges to ensure cohesive approaches to capturing the needs of people with neurological conditions, improving the recording of people's conditions in routine health and care records, and supporting the development of systems and processes for service planning and workforce development. Scottish Government have begun work to gather prevalence data, and this early stage work was published last month. Now, this session will look at how we can improve outcomes for patients by sharing the right information with patients and clinicians at the right time. We will hear from the projects in two groups. There will be an opportunity for your questions after each group, but each project has a limit of only 5 minutes to present their work to you, which we know is extremely challenging. So once we've had both groups and both question and answer sessions, you will be transported through the wonders of technology to breakout rooms where there will be an opportunity for further discussion, and those discussions will be facilitated and will come back together, and the facilitators will share the findings and have a final summing up session before we close at 1 o'clock, just in time for lunch. And the catering at these events on Teams is quite superb. But before that, it's my pleasure to hand over to Dr. Anne Wales, who is joining us here from NHS Education for Scotland. She is actually the programme lead knowledge and decision support at Digital Health and Care Innovation Centre, but is currently seconded to NES to undertake this work. She's going to give us an overview of the Right Decisions platform. And Anne, if I can hand over to you, you have 10 minutes.
10 minutes, okay. Thank you very much indeed. If it's okay, I'll just share from my own screen, just in the interests of speed and moving from one slide to the next. Thank you all very much for the invitation today. I do hope that what I can share with you about the Right Decision Service will encourage you to see opportunities to make use of it to support your work around the Neurological Framework. I'm Anne Wales. I'm the Programme Director for Knowledge and Decision Support. I'm based in the Digital Health and Care Innovation Centre, and I'm on secondment from NHS Education. So the mission of the Right Decision Service is to provide a Once for Scotland source of digital tools that enable staff and citizens to make safe decisions quickly on the go as part of day-to-day activities, and be confident that those decisions are based on validated evidence. To enable that quick decision-making as part of day-to-day work, these tools are delivered through day-to-day technology, web and mobile apps, and embedded in electronic care systems. Our mandate for the Right Decision Service comes first and foremost from Scottish Government Digital Health and Care, who have funded delivery of this National Decision Support Service. It's one of the commitments in their current delivery plan. It's also a key goal within the newly published data strategy for health and care, and it's also highlighted as a key enabler of value-based health and care in the vision statement published last December. The Right Decision Service, as a national service, provides a platform with the functions illustrated in this diagram. We provide within the platform a package of knowledge translation tools that enable us to convert guidelines, primary research, and evidence from lived experience into computerized knowledge in different formats. Sometimes that's in the form of structured rules or algorithms. Sometimes it's a less structured knowledge, for example, summarized recommendations for action from a validated guidance that are delivered in decision-ready format through web and mobile apps and integrated with electronic care systems. So it's a process really of translating the knowledge into a format that is decision-ready and can be accessed through digital tools, and then doing the delivery through web and mobile interfaces, and in some cases, integration with care systems. I'm just going to show you a few examples of the different types of decision support tool we can deliver. Many boards, 12 boards in total now, are using the Right Decision Service to provide access to local clinical guidance through web and mobile means. So this is an example from NHS Tayside, their emergency department guidance, which to date has resided in a huge series of PDF and Word and PowerPoint documents, all now translated into this nice digital format and delivered via a website and downloadable mobile app. All the content is nicely chunked up and segmented so that the clinician can quickly get to the specific bit of the guideline that is of interest to them. And that's sort of very simple kind of narrative type knowledge, but as I say, formatted to be actionable at point of clinical need. Then we have tools that enable delivery of knowledge in a kind of semi-structured format, for example, as visual pathways. So you can see here an example of a visual pathway that's embedded in our web and mobile apps. All the pathways are presented in a consistent format to reduce likelihood of clinical error, where poor junior doctors can't always follow the logic of a visual pathway if they're very complex. You have the option to include a little eye information icon in any node in the pathway that will open up a side panel that provides additional guidance, links to evidence, and patient information. And these pathways can all be pinched and zoomed to enable you to focus in on specific information of interest. At the next level up, our tools enable creation of algorithms that are very structured knowledge and executable, i.e. they actually perform an action on data that's entered into the web or mobile app. It's a very simple example about assessment of lower urinary tract infection in older people. We have one tool for care homes and care at home staff and one tool for clinical staff. This simple series of algorithms takes the clinician or care worker through a set of questions. Depending on what answers they give to any one question, they're then taken to the next step in the decision tree and ultimately to the recommendations for action based on the sign guidance. That can be taken one stage further, where the answers to the questions that the clinician provides, those answers can be the basis for calculating risk scores. So you can see here, for example, we have the 4-at tool for delirium assessment and various other risk scoring tools. These, as I mentioned, can all be created using our knowledge translation tools. They don't require any programming expertise. They can be built simply and quickly and then subjected to rigorous clinical testing. And the final type of clinical decision support we can offer is actually embedding these structured algorithms in electronic patient record systems. This is an example where we've converted 68 recommendations from National Polypharmacy Guidance into structured algorithms that interact with the primary care electronic health record systems. When the clinician opens a patient record, these algorithms detect any high-risk prescribing issues and push out alerts to the clinician in a decision support window in front of the patient record. The clinician can open the recommendation and then open the alert and see the recommendation for action. An example of using the Right Decision Service in neurology is that very recently, Greater Glasgow and Clyde Institute of Neurological Sciences has appointed a decision support manager, half-time for 12 months, to build a portfolio of Right Decision Service toolkits to support their local and national work. I'll finish there as I'm conscious of time. Happy to take any immediate questions if that's okay with the chair.
Thank you, Anne, and thank you for sticking to time. Can I just also confirm with everyone that slides will be shared after the presentation? Is that right, Richard and Ewan?
Yes, that's correct. I'll share that.
Okay. Anne, I know you have to go, so we've got time for a couple of questions. Does anybody, Pamela, you've had your hand up for a bit. Do you have a question for Anne? And Mary has a question for Anne, and I think that's probably all we'll have time for.
Pamela, are you?
Can you hear me?
Yes, we can. Yeah.
Okay. Sorry, I didn't actually realize my hand was up, but as it so happens, I do have a question. So thank you for the opportunity. You mentioned that the algorithms, Anne, were based on sign guidelines. If there is no sign guideline for a condition, are the algorithms then based on NICE guidelines, or where would you get your source from?
The algorithms can be based on any validated guidance that are recommended by the governance group that's in charge of a particular toolkit. I just use SIGN there as one example of where we've built a number of algorithms now based on SIGN guidance, but it's not limited to SIGN guidance.
Good question, Pamela. Mary, I think then we have to move on. So Mary, your question.
Hello, Anne. When you showed the algorithm about neurology, if you're looking at it, can it determine, say, for example, a deep brain stimulation or a focus guided ultrasound? Would it show up either of those?
We don't have that specific algorithm at present within the Right Decision Service, but you may be aware we do actually have a whole deep brain simulation toolkit that has been built, in fact, again by Greater Glasgow and Clyde, which provides a lot of useful information. As you can see here, about deep brain stimulation. So I can readily, I'll pop the link to this in the chat and you can have a look at that. If you feel there's content that you would like to see that isn't there just now, that's certainly something that I can take back to the group in charge of that toolkit.
I know.
Thank you. Sorry, Mary, I'm going to have to cut you off, I'm afraid, because we need to move on.
Email you, Anne.
Thank you. That's
thank you.
Thank you
so much. And thank you for setting the scene and talking us through the Right Decisions platform. We now have rapid case studies. We're going to take them 3 at a time. So, and I think we'll just hand over straight from one to the other The first one, I'm going to hand over to Professor John Stone, who is consultant neurologist in NHS Lothian, but presenting from somewhere far more exotic, I think. So, John, over to you, and I'm putting my timer on now.
Thanks, Stephanie. I've got my timer on as well for my 300 seconds. Thank you very much. It's great to be here and to partly say thank you for the funding that we've had for this project. This is, I think, one of 3 FND projects, or possibly more today, and I'm presenting on behalf of myself, but also Pooja Jain, who's in CogniHealth, who are our sort of technology partner that have helped with this. So next slide, please. So FND, most people on the call will probably be familiar with it. It's a really common, one of the commonest conditions in neurological practice. Probably about 10 to 15,000 people in Scotland with this problem, and perhaps 100,000 in the UK. Presents with neurological symptoms like weakness, inability to walk, tremor, seizures, and many more. And these are problems occurring because of an abnormality in nervous system functioning, rather than something that you can see on a scan or conventional test. Next slide, please. So in 2009, I made this sort of rather homemade site for patients with FND. It was the first one there'd been. It's been such a neglected and stigmatized problem. There was sort of nothing out there really. And it carried on sort of looking like that since 2009 and was in desperate need of updating and being easier to use. So with the Neurological Framework funding, we're able to build the new site. Thank you, Ian. There it is on the right, and also an app which we hadn't had before, and which people really appreciate apps. I hadn't realised how many people just struggle with looking at, even websites on a mobile platform. So that launched in July 2021. It consisted there was a lot of content from the original site, but also a lot of new content, rearrangements, things like a search button we hadn't had before, which was really important, a media area and things like that. Next slide, please. We're able to link this to NHS Inform site, which didn't have anything on FND. So I'm really pleased I was pleased to be able to work with NHS Inform to make a new page on that. Which links into this site, but also other organisations and resources for people with FND, including patient-led organisations. Next slide, please. So since just a snapshot of how things are going, well, we have about 60,000 users per month, or 60,000 visits per month, maybe 30,000 users a month. So there's about 400,000 in the last year. They're from around the world, actually, partly because of the lack of other resources. I think that's why this one has taken off. We spent a lot of time getting other languages going. So we've got Arabic and Farsi and German and Finnish, and they're kind of adapted because a straight translation of this area doesn't really work. You can see in Scotland we've got nearly 20,000 users in the last year, and in the UK 170,000. So that's a sort of snapshot of where it's being used. Actually, more than half of people in North America. Next click. And just one comment from somebody who's very pleased to have an app, and did comment how much easier it was to actually just find things. There's about 150 pages on the site, so it is quite hard to navigate. I think the app does help with that. Next slide, please. What we've done subsequently is we've made a new tool called the FND formulation tool. This is designed to try and improve communication between patients and doctors. Patients often bring long lists of symptoms and ideas about causes and treatments to clinic, and this was a way to try and formalize that and help people present their information to their clinic appointment. And also at a later date, well, we're currently working on developing this into a tool that people can use to monitor their progress, and also to then individualize their information so that they can see information that's relevant to the symptoms that they have, if they've just got seizures or tremor, and not information that they don't. So we're grateful for other funders for that. Next slide, please. So we've got some additional funding now from University of Edinburgh to make a patient database that's attached to the website, and which will be the start of a research platform. And we're beginning the work on making this individualized patient treatment content. It is a challenge once you've built something like this to maintain funding, but we're working on that. So I think my next slide, that's it. So my time's up. So thank you very much, everyone, and I look forward to speaking to you in the breakout session. Thank you.
John, thank you so much. You are a model presenter. Yes, we'll have some questions after the 3 presentations, but if I could hand over now, and you've got a tough act to follow, Phil, but Phil Sizer from the Pain Association, your 5 minutes start now.
Good afternoon, everybody. I won't be able to follow that so slickly, but yeah, Ewan, would you mind putting up the slide, please? I've mercifully only got one, but this maybe gives you a sense that we're in a slightly different place. So thanks to the neurological funding, so I work for Pain Association Scotland, and most of our work is usually focused on helping people with chronic pain in the community and delivering self-management courses and monthly groups for them. But one of the things that's always come up has been, people have always said, what about the person who looks after me? And so our focus in this project was realizing we don't have expertise in individual neurological conditions, but what we could do was to use, if you like, the skills of self-management and focus on helping carers. There was the idea was to help carers to help the people they cared for. So there were sort of 3 people we were thinking of helping. One was to help the carer, just because obviously they've got a lot going on. Then the other one was to help the person they cared for through the carer. And the third idea was basically to help both of them by hopefully getting them to work together on the kind of ideas we look at in self-management. So communication would be a very good example. So it's something where we were talking about in the course would be shared between both of them. One of the interesting things and surprising things that came up was an awful lot of the carers had long-term conditions themselves. So maybe this gave an unexpected 4th dimension to it, which was a lot of them either had pre-existing conditions, or maybe the caring was the straw that broke the camel's back. And the issue with, or the point of self-management is offering a non-medical approach to deal with many of the things that drive what you might call medical symptoms. So in the case of pain, stress, anxiety, lack of sleep, the balance of life are things that often present themselves as more symptoms. And so this is a diagram. It's actually an idea I came up with because one of the ideas in self-management is the biopsychosocial model, which is another way of saying working holistically. But I came up with the idea that really it's all a bit messier than that. And so this was my idea, that if you're living with a difficult condition, if you're living with a limiting condition, then it's not just about the symptoms, it's about lots of life issues. And helping somebody with all of that is about untangling a knot of issues. Often, if you like, the symptoms are the metaphor for all of the rest of this. But the other thing is that a lot of the rest of this doesn't actually get looked at by anybody. And that's the job of, if you like, self-management, to shine a light on this and to help people to untangle their own knots. If I was going to be clever with this, I should have drawn two diagrams, which is one that the carer has a knot and the person they're caring for has a knot, and maybe both of them get tangled up with each other. So in very simple terms, the project was about helping people to untangle their knots, both for themselves and for the person they're caring for, and together. We did a number of 5-week courses, but the other thing that came out of it, there was quite a lot of interest in me working 1-to-1 or 1-to-2 with couples. And that was something very interesting as well. Group work's helpful because it helps people to feel like they're not on their own, but the 1-to-1 work was very useful as well because it helped to zoom in on issues people perhaps wouldn't want to share in groups. So that's it really. I'll stay to time, hopefully. Is that all right?
You've been excellent, Phil. Thank you very much.
Good.
And your contact details are in the slide. And I now can hand over to Professor Martin Dennis from Edinburgh University, who is going to talk to us about tailored talks.
Thank you very much. So I'm presenting on behalf of my colleagues working in Chest, Heart and Stroke Scotland, NHS Lothian, the Edinburgh Headway Group, and also our IT partners, Pogo Studio, who have developed the technology. And this is just the landing point for our web-based platform called Tailored Talks. And I'm going to talk mostly about the use by clinicians, but there is also a patient portal, which I will allude to at the end. Next slide, please, Ewan. So Tailored Talks is a web-based tool we developed in Scotland to allow clinicians to tailor information to individual patients and their families, and to be able to share that with them digitally. That might be on screen, it might be via email, it might be on screen in a clinic or over a virtual consultation. One might do it at the time of a consultation or before or after. One can also share the information on paper as we would traditionally do by simply printing it out, but it can be tailored to the individual. We can also keep that as a permanent record of the information shared to improve consistency along the pathway. Patients often complain that they're given different information by different healthcare professionals. Our aims in this project were to provide patients with relevant information in an accessible multimedia format, not just written words, text, but video, pictures, etc. To support their involvement in shared decision-making, making the right decisions, as we've already heard from Anne Wales, promoting the idea of realistic medicine. And the diagram on the right shows you some of the sort of information we might be sharing with a patient to help them make a decision about the treatment. And also we use Tailored Talks to signpost them to relevant services and self-management tools. For instance, the FND self-management suite, which John alluded to. Next slide, please. We've worked with clinicians and relevant third sector organisations to produce information, over 1,700 slides, for patients with 22 neurological conditions. And this information can easily be edited, updated, and added to. It isn't complicated. We have further developed Tailored Talks to allow clinicians to slickly search for information relevant to their individual patients, for services to be able to monitor their healthcare professionals' use of tailored talks, and also to allow all users, that's clinicians, patients, and all their families, to feed back on the Tailored Talks platform and to feed back on the content. And on the right there is a picture of the feedback slide, which allows you to give a star rating to the platform or the content. You can add comments, and you can make it anonymous, or if you want to get people to get back to you, you can add your email. We've tried to raise awareness of tailored talks amongst all healthcare professionals working with patients with neurological conditions across Scotland, and also third sector organisations. And since April 2022, we've offered free access to tailored talks and relevant training to any healthcare professional requesting it, whether they're in the neurological area of practice or indeed across all the stroke services across Scotland. Your next slide, please. Our next steps are to continue to raise awareness and to encourage healthcare professionals to register to use the service, to access training, and to use the system to share information with their patients. We plan to add more information to the Tailored Talks platform. And at the moment, for instance, we're working with the Brain and Spine Foundation to add over 100 slides on subarachnoid hemorrhage. Acknowledging the fact that healthcare professionals have limited time, especially at these hard-pressed times, to spend their time familiarising themselves with this sort of new system and to spend their time sharing individualised information with patients, we're developing My Tailored Talks, which is a mobile app which allows patients or their families to request information relevant to them, to store all the information shared with them in one place, and also some tools to allow them to monitor their condition and to contact relevant healthcare professionals, what we call care partners. Your next slide.
That's your 5 minutes, Martin.
Thank you.
Yes, thank you very much indeed for sticking to time, everybody. You've been absolutely excellent. We now have the opportunity for questions on any of those three projects or to our Scottish Government and Neurological Alliance colleagues. And I would ask you to raise your hand and I will come to you, or if that's not possible, we will be able to look at we'll be monitoring the chat. So for any of those projects that we have just heard, are there any questions for any of the presenters? Okay, Fiona, can I come to you?
Yes, I suppose this is really partly Phil in his presentation. I loved the slide, by the way, but on looking at that, all of those things around there pretty much cover things like FND and lots of other conditions that are very, very similar. So one of the things that we've been pushing for in Grampian, and hopefully one day might happen, is a kind of what we would call a functional practitioner or a practitioner in FND. But when we spoke to patients, they said they wanted somebody to hold them. That was what the words they used. We want a holder, somebody we can go to. Is there something that you think could you have a holder across different kind of conditions?
That's the day job, Fiona.
Yeah,
in that the work I do, I don't ask people what their conditions are. So what we do is we work with the principles of self-management. So we're trying to get away from a medical model that sometimes traps people somewhat. We did have a group. I mean, the way we deliver our work is usually through groups because you get more people. We did have a group in Grampian that unfortunately ran for a year and then had the funding pulled. So it's the kind of thing that, you know, I think holding people, if I get the sense of what you mean, is something you can do with a group in quite an effective way, especially if it's on Zoom. So that was something we were offering and be keen to do again if anybody wanted us to. But that's a very good point.
I guess it's also a question for Scottish Government, as in this is a different way of working, not being disease specific, but being symptom led really, and being led by patients having somebody to go, I've got pain, or I've got a diet issue, or I've got whatever it is. Is that something the Scottish Government looking at, widening and getting away from that medical model? And then I'll stop.
I could come in on that one just briefly. We have funded quite a few self-management projects, and the other day I was at a celebration event for the Quarriers Wellbeing Self-Management Project, which is another really good example, quite similar person-centered work to what Pain Association have been doing. We need to try and find ways of making these projects sustainable and scalable. And I'm not, the money is not going to come long term from Scottish Government to do that. So we need to find ways of moving the conversation around to being able to make those projects stick at a local level. And I suppose the other thing is that this came up at one of the sessions we ran in December. It's around how people find those projects, and clinicians don't always know that they're there, and they don't always know how to navigate towards them. So maybe that was going to be my question for you, Phil, is how do you let people know that this is there?
It's a great question, Richard. It's tricky. Traditionally, you would always imagine through medical routes, but that seems to. I've been doing this work for 23 years, and that doesn't tend to work terribly well unless you have a very specialised service. So we often work a lot with specialised clinical services. But what we've also been finding is we've been using social media much more. And in some ways that's it's taking time, but that seems to be quite a valuable way of reaching people, perhaps who have fallen out of the system as well. And that's something we're working on, is just to try and keep using social media. But the other one is, the classic is through people's GPs, but I think there's so much information out there, perhaps it just doesn't get through, or people don't get why self-management would be useful.
Phil, just there's a question in the chat, which I'm assuming is to you. Would spina bifida be a condition that you would provide support for? I'm assuming that you are not. Your point is that you don't look at the condition. So,
yeah. A bit like my diagram, what I'm looking at is life rather than the condition. Okay. So if life is contributing, and people get that life is contributing to their problems, then and it always does. Then I would say, of course, anything really.
Okay. Mary, you have your hand up.
Yes. I have a question, and I'm not sure if any of the three speakers can answer it. There is a neurological condition called essential tremor. There is a treatment called the focus guided ultrasound. Now, due to the Scottish Government, they are talking about sending patients from Scotland to either Liverpool or London for treatment. Now, I know for a fact London has a 4-year waiting list. Liverpool is only just started up. Is there any way you can suggest helping me to get the Scottish Government to do a U-turn on this? Because we've got a perfectly good machine in Dundee, and you can do Dundee.
Mary, I think the questions we were asking for were on the projects and on the presentations. I think you've made a very valid, you've made a very good point. We have Scottish Government colleagues on the call, and I am fairly sure that they will have noted your point and will probably be in touch with you out with this meeting.
Well, hopefully so, because it's been 8 years in the
Okay,
process.
noted. I'm going to move on to the next rapid case studies. We have the next 3 with your 5 minutes ready to go. So Fiona, from Dr. Fiona Summers, consultant neuropsychologist from NHS Grampian, it's over to you.
Great, thank you. Next slide, please. That's quick. Just talk you a little bit about the project. This was trying to support GPs with supporting patients managing their FND. We had 2 GP clusters, one in the city that had 3 GPs that regularly turned up, or that did turn up to all of them, and one that was in Orkney had 10. They had 2 different approaches. The one in Aberdeen City was 3 GPs. The one in Orkney was actually AHP, so included physio, OT, and others. It was a 1-hour session once a month for 6 months. We measured pre and post knowledge, the rating of referrals, and down here is your kind of scale of this. The neurologist came up with this as what they would see is helpful in a referral and unhelpful. So we had 50 referrals from before we started the sessions and 50 after to look at quality of referral. The other thing we wanted to also look at was healthcare utilisation pre and post, which is a little bit trickier, which I'll come on to. So next slide. The challenges and lessons learned for us, and this is still an ongoing project, is that we had been due to end in July 2022, but actually it won't be until August this year. The projects, the teaching and supports finished this month, but because we want to do some of the follow-up data, it takes a little bit longer, and really COVID and everybody around the table knows the pressure that GPs are under just now. We decided not to collect the healthcare utilisation. 2 issues around that. One is we engaged staff to do that, and of course, because then we couldn't get the GPs on board until later, there was an issue with that, so we didn't have the resource, although we've collected some data. Call-to-cop is an issue with GPs, and that I think generally is an issue for, I've had another larger project, and because GPs hold their own call-to-cop, we have to go around each GP surgery to ask for it, and that's very time consuming. And some say they'll accept the NHS Grampian ones, some say they need their own call-to-cop done, and some were asking for a whole ethics proposal. So it's difficult. And also systems of data collection are difficult within the NHS, particularly in FND, because there isn't kind of an FND at that time kind of category. So we'd have to do that literally by looking at the referrals and then looking at letters that have come from neurologists saying, is this FND or not? Next slide, please. So we've had very good informal feedback, poor return rate of questionnaires, which we are chasing them up because that's just happened in the last couple of weeks. The referral metrics are still being collected, and the neurologists are kind of rating those referrals to see if those referrals are clearer. And it's made a change in referral numbers generally to neurology, but potentially more specifically to FND. A range of topics were covered around FND. There were case discussions. Teams worked well using Teams and developed certainly good links between, for example, Orkney, which was where one of the sessions the group was from, and the other GP's surgery. The feedback from the GPs informally has been that they have seen patients that they might have referred back to neurology and are not doing so anymore because they realise it's a relapse and are able to talk through that. And also that in terms of explaining the diagnosis, they feel much more equipped to do that, which is great. However, you know, it tells us that there's something about teaching sessions per se that's not quite capturing it, and having that additional one-to-one support and making those links is, but quantifying that. And for us, the question is this generalizable? Can we roll this out? Is that the cost benefit of that is a big discussion to be had. So that's where we're at. And the last slide is just my email and who the neurologists were who took part.
Thank you, Fiona. I've obviously scared you all witless.
Oh, have I done that really quickly?
You're all totally to time, which is fantastic, and we are absolutely spot on. Excellent. So we will come to questions. You know, with this group, we have another session after the 3 presenters, but now I'm delighted to hand over to Melanie and Jill from NHS Lanarkshire to talk about the brain injury self-management programme. Melanie and Jill.
Thank you. Good afternoon, everybody. My name's Mel and I'm here with my colleague Jill, and as you've said, we are from NHS Lanarkshire's community brain injury team. We're both occupational therapists who have been working with the team. Can we move on to the next slide, please? So our proposal was that we were going to take a peer support that we did pre-COVID deliver face-to-face that looked at various topics around self-management that our current patients we were working with were interested in exploring further into an online programme. So we successfully secured a bid in 2021, and from there we had multiple stakeholder meetings with our partners and patients and their families, as our online programme was going to be aimed at people who were both living with following a brain injury and to support their families as well, in a way of them helping them to take control of their residual difficulties following their condition. We began by analysing our online, or taking our peer support material that we were using from our face-to-face groups and developing video presentations and delivering Near Me sessions, which is a kind of online platform that is used within NHS. We then, from there, produced questionnaires and pulled together feedback from those questionnaires to develop the material and the topics that we were using, and we took that into a telephone questionnaire, speaking with both past and present patients, as well as some caregivers and family members, to identify topics that may be of interest within a self-management programme. We then identified website support from website designer and our communications within NHS Lanarkshire, and they've supported us to create a landing page and develop our module templates so that there is conformity throughout each of the modules. And we have recruited further personnel and support in developing these modules from our multidisciplinary colleagues, both from occupational therapy, physiotherapy, psychology, and as well as that within our partners, again, at leisure and within social work. Next slide, please. So we've identified a location for our website. It's going to currently, it will aim to be sitting within the NHS Lanarkshire directory. However, it will have its own unique domain name, so that it's easier to access for all. As it said, we've completed our landing page, and we are in the process at the moment of developing our modules. We have formed an editorial committee who are reviewing the material that's being produced, and we're working with our communications team to build or create videos, and website designer to build the website itself and take this material online. Where our comms team will also be involved in, kind of launch and advertising, so that people are aware that the website is there once we go live. We've completed appropriate tools, so there was quite a lot of background stuff that I think we were very new to all of this, and possibly a little bit naive. So we had to have a wee look at you know, whether this was going to be a research project as such, in which case did we require ethical approval. However, we have decided to forge forward with a quality improvement project. So this will enhance the service that we provide at the moment.
Thanks, Mel. So part of the measurements that we will be using on the website for it going live for part of the evaluation will be further using Likert scales, questionnaires. So some of these will be drop-down boxes when the patients first sort of make their first approach onto the website. So we'll be using cookies to monitor the hits. We've got a pre and post module confidence and knowledge kind of questionnaire, just a simple question that will appear at the beginning, at the end, and the Likert scale rating will tell us in terms of how much knowledge they have regarding in terms of managing their fatigue, their pain, their anxiety around their brain injury, and then once they complete the module, how that differs. We also hope that just the group that will be looking at this, our brain injury patient group and their families, the aim is that they'll be able to access the programme at any time or any stage of the recovery. So it's very much looking at this non-medical model, and the ethos is very much looking at developing their skills and self-management. It can be supported self-management where they're working alongside us when they're referred, and at the same time we'll be referring them to the website, or it may be that we're tasking them with some things to do to try and promote the self-management. And one of the main aims that we want to do with this is for people to feel very much in control of managing their health condition, rather than being done to. They're very much in terms of in control with this. So next slide, please.
That's your 5 minutes, I'm afraid.
5 minutes. I know we do have a lot to say. Do I have any time to say anything on this page? So basically, we are finalising our module materials. We are looking for a sign-off from our evidence manager. We've used QI tools. We will be trialling it with a small cohort on the website. There'll be a publicity launch and a website that will go live. We are hoping that will be sometime in the summer. Obviously, I think the previous speaker mentioned the advent of COVID. We were all redeployed, and we are kind of on catch up with the project, but we're all very much good to go, hopefully within the next couple of months, and we're working hard on it. And this is the way. And yeah, okay, thank you. And that's our contact details.
Thank you very much. Contact details are being posted in the chat. So I now have great pleasure to hand over to our final rapid present case study, which is NHS GGC, and Dr. Sharon Mulhern is presenting. Is Dr. Razvi with you? I can't quite see. But yes, over to you, Sharon.
Hi, everybody. Yes, so it's myself and Safe that are presenting this presentation today. So next slide, please. So what we aim to do is develop an educational app for patients who have a diagnosis of psychogenic non-epileptic seizures or dissociative seizures. And the aim here is to have a self-management resource, which, similar to what you've already heard today, is that it will be hosted in the Right Decision platform via the NHS GGC Mega app. And we really wanted to offer a range of information from the point of diagnosis through to common features patients experience, contributory factors, and really importantly, how patients can take ownership and control and look at self-management. We've engaged as widely as we possibly can, including stakeholders, which has been patients and carers, and we've also scoped expertise from clinicians working in Glasgow, Grampian, Ayrshire and Arran. We've worked widely with a number of different partners throughout the health board, including library, medical illustrations, IT services, and essentially what we're doing at the moment is we're still in the development stages of the app. Next slide, please. So what we've been able to achieve so far is quite successfully engage with service users to develop the themes and the resources. Importantly for us, we wanted this to grow from ground up and not top down. So we wanted to ensure that anything that we developed really mirrored what patients felt was either missing or was difficult to interpret from clinical contacts. We've interfaced with across Scotland, as I say, with a range of clinical expertise, and this has ranged from neurology, neuropsychology and psychiatry. And we've developed interactive resources, really taking advice from some of the more sort of technology literature about different platforms and ways to interact through apps. We've utilised as much as we possibly can existing resources that already are embedded within NHS Inform. And as I say, very much this promotion of self-management and this holistic approach, which you've already heard about today. Some of the self-management resources that we are developing, we're hoping can be used even broader than within the dissociative seizure app, and can be used for other platforms and other neurological conditions. So hoping that it will have a multi-purpose. And again, housed in a platform that could be monitored and updated. Measures that we have so far, we continue to interface with our service users and clinicians to review and develop, to review the developments that we have to date. Our plan is to have a soft launch to collect feedback from service users and clinicians soon, and then obviously how we're going to monitor usage of the app as we move forward. We hope that it will be quick, easy and free to access, and really a reliable source of information from the point of the diagnosis by the neurology colleagues. We want it to be easily shared with significant others, so when we've developed the app, we've thought about it not just from the patient's perspective, but for anybody who may come into contact with this diagnosis and wants to understand more. And we really want to address some of the challenging questions that the patients have put forward that they felt haven't possibly been addressed, or there's been difficulty getting their questions addressed in clinical consultations. We really hope that it will promote patients' role in their quality of life and essentially living well with the diagnosis of dissociative seizures. Next slide, please. So where we're at the moment, and our next step is to complete all of our pages on the basis of the thematic themes that have been identified. This unfortunately has been negatively affected by the loss of our research assistant who was working in the project, and then the subsequent recruitment that we had to take on. We're at the point of completing a lot of our interactive platforms, such as the Talking Head, Face to Camera and Powtoon cartoons that we're utilising as different platforms to share the information. We'll look at the design and the function through, again, these other focus groups and clinicians, linking in again with our clinician working group, but wider. We're hoping for a soft launch or a trial run and feedback from patients and carers who participated in our prior workshops. And we're looking for feedback from clinicians, and we're building up a database of clinicians to contact in addition to our working group. And then essentially we would incorporate all of this feedback, and our hope is to have a launch of the app in summer of 2023. Next slide, please. And this is just Safe and I's contact details. So I think I've kept to time.
You have, you have 32 seconds left on my timer, but thank you so much. And before I open it out to any other questions, what's a Powtoon?
Oh, so this is basically it's an animation. It's a form of animation, cartoon animation, where you can you basically build up the movie of the information that you're wanting to deliver.
Sounds amazing.
And I found out about it through my kids who use it in school and say it's absolutely brilliant. So that's how we found out about it.
Oh, well done you. Right, I'm going to open up to the meeting. Please just raise your hand if we have a few minutes to ask any questions about the projects that have just been presented in that group. Okay, Ewan, Dale, I'll come to you.
Hi, if you can hear me clearly. Fiona, you were talking about getting referrals into the system for FND, but are you able to monitor progress of differential diagnosis if you're getting people getting referred early? Because obviously you're getting unclear symptoms which are presented often in the early stages of the whole range of neuropathy. And the other point was with monitoring cases or using notes, again, was you finding that there was re-diagnosis coming out in cases from seeing those notes?
We don't have the answer to that question. Yes, that will come out when we're actually looking at the note and rating them. And then what we're going to do is the ones that were referred in, what was the final diagnosis? And how did that match with the information that came from the GP? So we will be able to do that, but we just haven't done it yet.
Okay. Can I just ask Melanie and Jill, once the website and the program's up on the website and everything, how and who is keeping it up to date?
Yeah, I think we're going to have to, that will be something that we'll need to decide, but it is going to be moderated, and I think it's going to have to be us or through our service.
Yeah, I would imagine, you know, it will obviously be monitored by NHS Lanarkshire itself, and then we will kind of be involved from a specialist point of view with regards to any, you know, updates and best practice with regards to brain injury.
And there may be add-ons that we do for the development on the website as time goes on as well.
Thank you. Richard, over to you.
Yeah, just it's also questions for Melanie and Jill. And one of the purposes of these sessions is to bring people together and to try and make the links to one another. I wondered if you had any thoughts, having heard from Anne as the first presenter about the Right Decisions platform, if that was something that you thought might be a good location for the self-management app.
Yeah, no, it was really interesting because I think we both said as soon as we heard Anne speaking, especially with the evidence from lived experience and the downloadable app, we do hope that we can, you know, take this forward to an app as well. So absolutely, I think it'd be great to network with Anne and see if we could have it sitting more within there, as well. I think Anne's gone, hasn't she? Now
yes, I'm afraid she has, but her contact details are in the chat and have been shared. So do feel free to use them. Jenny, over to you.
Thank you, and thanks everybody. That's been a really interesting and informative morning, and I'm really enthused by all the work that's going on. Just a couple of things though that have come to light recently is the number of people that I see in my role as an occupational therapist who are telling us that they're no longer in a position to be able to afford internet. So therefore, how do we make sure that people who aren't able to afford the internet or choose not to access the internet, how do we make sure that they're not disadvantaged when a lot of this really excellent work is on that platform? And I suppose the other question relates to that as well, on the basis of when we're dealing with cognitive impairments or people with cognitive impairments, how do we make sure that, you know, some of these platforms are just as accessible for them too? Thank you.
I think we can.
Yes,
we've come
Amy
across
and
this.
Melanie,
Oh, sorry. So we've come across this with our online peer support group, and sometimes we have to help them facilitate, because some of our patients, due to cognitive problems, sometimes visual problems as well, can't do that unaided. So we've had assistant practitioners kind of do some practice with using the Near Me platform, and sometimes they still need some help. From our point of view with our programme, we're thinking maybe that we use it with them and a family member, and then that can still be facilitated by the family member to so they're not disadvantaged. But yeah, the access on the internet, that's something out with our
we do have access to some iPads and laptops that we do use with people obviously that we're working with, and we also look at supporting people to local libraries and looking at accessing, you know, kind of IT suites and things like that where possible. But yeah, it's definitely a tricky one.
It's a big and ever-growing issue. John, over to you. You have a question.
Yeah, well, I was just going to respond.
Or a comment. Yeah.
I think it's a really good point about it's not just having internet, it's just people who just don't like looking at digital things. They just don't want to do that. And I think there is a general tendency to feel perhaps we can save money or replace health services with lots of digital health. And I don't think we can. I think these things can be really helpful for people. I don't regard digital information or even what I'm planning to build as a treatment as such. I think it's something that can help some people. I think it's really important when we're building these things to think, how can we make them accessible to people who don't have a computer. So, for example, I've got about 12 different fact sheets that the clinician or somebody could download and give to them. But I think it's a really well-made point, and it highlights the limits of digital health, I think.
Yes, I think that's a good point to note. And you know, just because we do something online doesn't negate the importance of remembering what we have to do in person. I think now we are going to be transported into our breakout rooms. Is that correct? Yes. Alice and Lorna are nodding at me. That's marvellous. So if you just hang fire in there, if it all goes wrong, then you should be able to rejoin using the link that you used to join in the first place. But enjoy your breakout rooms, and we'll see you back here once we've done that. Thank you. Welcome back, everybody. I was literally cut off mid-sentence in our group.
We had no choice about coming back.
Yeah.
I hope you all had a happy discussion. Lorna and Alice, is that everybody back to where they need to be? Yes, good. Well, thank you very much for contributing to that. I'm now going to ask the three facilitators to just feedback briefly on the themes that came up in your discussion in your room. So, Richard, can I start with you on that?
Yeah, sure. And our discussion was so lively, I didn't get the opportunity to check in with my group to see what points they wanted me to feedback. So I've just picked them myself. So if anyone that's in my group wants to chip in, please feel free. I mean, I think the first key theme that came out from ours was there's an awful lot of self-management and digital resources that we've heard about, and just a note of anxiety that the plethora of what we have will create chaos in focusing patients towards the right services and self-management. And I think that the other thing that had resonated from the plenary before is that idea of actually people needing direct support, not just digital tools. So it goes back to what Phil said about people just needing a hug and needing access to that specialist face-to-face support. And then finally, again, sort of playing into those two themes, about how people that are referring patients on know what's out there and are able to easily access the information that they need to refer people on to those services. So those are my 3 points. Thank you.
Thank you. Thank you very much. Anissa, from our group, did you manage to get 3 key points, do you think, that you can?
Pretty much. So we talked a bit about how we access the information which is generated by projects as a byproduct maybe of the projects. I took away maybe a bit of an action point about looking at our Scottish Government website and its role within some of that and how that might be improved. We talked a bit about you know, projects have given lots of sort of factual information, but how we zoom out a bit to find common approaches, guiding principles around supporting individuals. And we talked about the tension between sort of generalised approaches versus very specific person-centred approaches. And we, towards the end, we talked about how we highlight how, or at least how we move forward with sort of information and services around conditions where really there are no clinical champions, and where there's little awareness perhaps amongst clinicians. And I again took from that a bit of an action around looking further at our intersection between our neuro work and our rare diseases work, because we have colleagues working around rare disease kind of framework, and how these things intersect, because they come together, I think, on a number of fronts.
Thank you, Anissa. That was a fantastic summing up of the room I was in. And Keith, over to you. You were facilitating the 3rd breakout room. What 3 points can you feedback on?
Well, I managed to change
sense check 2 of them. The third one, I get cut off mid-sentence, so I'm not sure how if everybody will agree. So please again chip in. The first thing that sort of was raised with us was there's so many projects that are taking place, and it's how everybody can find out what they are and whether they can add anything to those. So also there's other organisations out there who might be doing something similar and can share information or experience to actually add value to what people are delivering, and even just share some of the issues that others are having when they're doing that, to try and go over some issues they're having. Other thing is, again, I think Richard touched on it, there's so many projects out there and there's so many digital platforms and apps that are there. So like, where can they all be sourced somewhere and kept somewhere? So like in a neuro hub where people know where to find that information, so there can then be links made across it between different platforms and different apps. And then finally, again, just exploring further the fact that we're doing quite a lot of digital exploration and things online just now. It's looking at some of the issues around cross-health board referrals for some of these issues. So if somebody's running a service, example, Fiona was saying she was running a service in Grampian, can people from Ayrshire and Arran who might benefit from that be able to get referred into that and simplify that process so that one service is set up in Grampian, but it can benefit people from across the whole of the country, and how we can get around that. There's lots of issues around confidentiality and data governance, etc. around that, but again, it's something that we'd explored and discussed.
Thank you very much to our 3 facilitators. I am very grateful to you, because that's no mean task, trying to find 3 points and feedback that quickly. So thank you to our facilitators. Thank you to all those who have presented today. It's been very thought-provoking, and it's interesting that in all 3 breakout rooms, the plethora of resources and the wealth of the work that has been done has come up as an issue that how do we share that? And I think what we've done today is challenge our Scottish Government colleagues really to look at how they, as if you like the controller of the projects, are able to not only share the information in a more granular way across Scotland, but also how do we share this with other areas of work within Scottish Government so that we're becoming more coordinated, and as Keith just said, how do we enable cross health board working to happen, and I think the final thing I want to reiterate again challenging back to our to all of us, is that people do need real support, not just digital tools, and that we mustn't forget that. And but anyway, today was just a taster. I know it was extremely challenging for all of the projects to sum up their work in 5 minutes, and I thank you all profusely for sticking to time. I hope that what we've managed to do is to facilitate some introductions, and as I say, contact details have been in the chat and can be shared post this event. So please, if please do follow up with various people as a result of today. In terms of immediate next steps, there will be a Slido poll in the chat. So please click on this button and fill it in. I don't quite see it at the moment, but I'm sure it will be there shortly. Or a Slido poll will be posted. There will be a more detailed survey that will be sent to all attendees. Please, please, please fill this in and return it, because this is really important, as it gives us and our Scottish Government colleagues the information they need on how to do this in the future, or how to do things better, or how to follow up on things. There is a Scottish Government neurological website that covers specifically this area of work, which Anita just referred to. A link, so please use it and go and explore the projects on that. The Slido button, sorry, I'm just reading the chat. Slido button's at the top of my screen in the menu, so please click on that. But anyway, please go to the Scottish Government Neurological website covering this area of work. There is a link in the chat, and colleagues will send out copies of the presentations and all the project information again after this session. So all that remains for me to do now is, again, remind you about that Slido button, but to thank you all for attending. It's been a very
fascinating morning, and I really appreciate that so many of you have given your time to attend. I look forward to seeing how we can develop this work further and how we can fulfill what we all want to do, which is to make a real difference for people in Scotland living with neurological conditions. And I think now, to time, I'm going to officially draw this event to a close and hope that you all have a very delicious lunch. And thank you all for attending. Bye.